Hi guys, good evening, good evening. Can you all see me? Can you all hear me? A quick feedback. बहुत दिनों के बाद we're doing live. How's everyone? Good evening, good evening. Can we all start? All right, so today's objective is to cover the previous year questions of your INICET. We are going to keep the discussion absolutely crisp. We'll keep it to the point. Zada isme we're not trying to give you a lot of gyan. Whatever is precisely important for you to revise right now is my concentration. Good evening, guys. Good evening. Good evening. कैसे हो सब लोग? All good? How is the preparation for INICET going? है ना? चलो, let's kickstart the discussion. All right. So we'll start with the first question that we have. So the first question that you have, a child presents with cleft lip and planned for repair. Which muscle will be repaired first during the surgery? This was the latest exam question. Obviously, the first muscle in the cleft lip, if you look at the option, your orbicularis oris, oculi, zygomatic major, and levator anal nasi, right? So obviously, the one which is going to be around the mouth will be repaired first is your orbicularis oris. So answer here is A for Ahmedabad, right? Nobody's going to again repeatedly ask the same question because it's a simple question. What they can ask you is, what is this classification of the cleft lip and palate called as? The classification is what we called as LAHSAL classification. This classification is called as the LAHSAL classification, right? So what is this classification basically called as, right? Now this classification, as you can see, it starts from the right side. So the first letter indicates of the right-sided defect that you're talking about. So this is the right-sided defect. This is going to be the right-sided defect, and this is the left-sided one, right? So this is the right-sided defect that you're talking about. This is the left-sided defect that you're talking about, right? Now, L stands for lip, A stands for alveolus, H stands for hard palate, S stands for soft palate. Another A is alveolus, L is your another left lip that you have, right? Now, if I write a capital letter, it is a complete defect. It is a complete defect. If I write a small letter, it indicates incomplete defect. It indicates incomplete defect. If I put a dot, dot indicates no defect. Now, for example, I have a patient, if I write it like this, right? I'm writing a capital L, then there is dot, then there is dot, then there is dot, then there is dot, right? Then there is dot, and then you have small, right? What does it indicate? Now, there is a complete cleft lip on the right side. There is no other defect and a partial cleft lip on the left side, right? This is a complete cleft lip on right side. This is your partial cleft lip. There is a partial cleft lip on the left side. So this is how you abbreviate. This is how you're going to abbreviate your cleft lips and palate. So remember, LHSAL classification. L stands for the lip, A is your alveolus, H is a hard palate, S is a soft palate. Another A is the alveolus on the other side, and the L is the lip on the other side, right? So it starts from right, goes to left. Right to left is the direction and the orientation to be remembered. Now, what is your repair criteria? Now, if it is only a cleft lip on a unilateral, on a single side, then it has to be repaired in 5 to 6 months. Bilateral cleft lip should be repaired in 4 to 5 months. If it is soft palates, at the 6-month, hard palate should be done with 2 surgeries. Soft palate should be repaired at 6 months and hard palate should be repaired at 15 to 18 months. Now, if it's a unilateral cleft lip and palate together, then you have to do 2 surgeries. The first is going to be cleft lip at 5 to 6 months. The hard palate should be done at your 15 to 18 months, right? Same if it's a bilateral cleft lip and palate. In bilateral cleft lip and palate, So the bilateral cleft lip with soft palate will be repaired in 4 to 5 months, and then the hard palate is 15 to 18 months. Same thing. So cleft lip and palate, soft palate is 4 to 5 months, hard palate is 15 to 18 months. This they've asked you multiple times, the repair criteria of each individual. But each individual, you can see 1, 2, 3, 4 dots. How many dots did we put? 1, 2, 3, 4. Achha, did I put 5 dots? Sorry. Okay, 4 dots. Clear? So this is with respect to cleft lip and cleft palate. Usually the questions come from this particular side. Now question number 2 that you have, I have a 65-year-old patient. I have a 65-year-old patient. I have a 65-year-old patient on mechanical ventilator. Patient is suffering from ARDS, right? Suddenly develops hypotension. There is tachycardia and absent of breath sounds on the left side. Okay, the trachea is deviated to the right side. Okay, breath sounds on one side and trachea deviated to the opposite side. On ventilator, spontaneous perforation can occur of the trachea or the tracheobronchial tree, resulting in your tension pneumothorax. Intubated patient suddenly developing this features where you have absence of breath sounds on one side, trachea deviated to opposite side, it is going to be tension pneumothorax. So why will it create tension pneumothorax? It is not because of increased tidal volume. Yes, it can be because of barotrauma to the pressure. It is not because of ET tube malpositioning or oxygen toxicity. Answer here is B for Bombay, as rightly said, right? So here it's a case of tension pneumothorax, right? Now, why will you have tension? Why will you have hypertension tachycardia? Reason for hypertension, tachycardia, and tension pneumothorax. Anybody? Tension pneumothorax is known to cause what? Obstructive form of cardiogenic shock. It causes obstructive form of cardiogenic shock. Obstructive form of the cardiogenic shock. It is known to cause or form obstructive form of the cardiogenic shock. Now, this obstructive form of the cardiogenic shock, what is shock? Hypertension or tachycardia, and that is what it is going to create, right? So obstructive form of cardiogenic shock will be created here. Now, this is the table that I actually swear by every single time we talk about the thoracic condition, especially in trauma. We have 4 conditions that we're going to compare: the tension pneumothorax, open flail chest, and pericardial tamponade. As the definitions are, pneumothorax is collection of air, tension if the air is leaking within, open if it is air is coming outside. Definition of flail chest, more than or equal to 2 ribs fracture which are in continuity with more than or equal to 2 different sites on the same rib is what we call it as the flail chest. Pericardial tamponade is a collection of fluid between the pericardium and the heart and not allowing the heart to have an adequate systole and diastole, resulting in obstructive form of cardiogenic shock. So 2 things which causes cardiogenic shock, which is obstructive form: tension pneumothorax, pericardial tamponade. Both of them are now going to cause an obstructive form. They're going to cause an obstructive form of your cardiogenic shock. It is an obstructive form of the cardiogenic shock. Yeah, if you give high flow rates, obviously that causes severe barotrauma, and that is because of that, right? Now, what is the mode of injury? For tension, it is blunt trauma. For open pneumothorax, it is penetrating. For flail chest, it is blunt again. For your pericardial tamponade, it can be both blunt as well as your penetrating injury, right? Remember, to create an open pneumothorax, I can't take a small pin, poke it, and say it is creating open pneumothorax. No, there has to be a minimum size of the, I would say, injury. The minimum size of the injury has to be either it is more than 3 centimeters in diameter, or it is more than equal to 2/3 of the tracheal diameter, and this is also called a sucking chest wound. Now, what are the clinical features? So the features that you'll see in dyspnea, tachypnea, chest congestion, and trachea deviated is what you're going to see. In tension pneumothorax, you have all of them. Trachea is always deviated to the opposite side. Whichever side the tension pneumothorax is there, air fills up, the trachea pushed up onto the opposite side. Same thing with open pneumothorax. What is the differentiating factor? In an open pneumothorax, you will have presence of a sucking chest wound, whereas in tension pneumothorax, there is reduced air entry on the affected side, absence of breath sounds, hyperresonance, and distant neck veins will also be seen in open. So what is the difference? In open, you'll also see sucking chest wound. In flail chest, you have dyspnea, tachypnea, may or may not have chest congestion. Trachea is always central. Remember, on examination, there is presence of paradoxical breathing, and that's the most important pickup point, right? Okay. About the strategy of INI, don't worry, we'll discuss it when we are done with the TND. We'll talk for a bit so that you understand that what to do, what not to do. But let's concentrate on the questions now. In pericardial tamponade, you have Bextrad, which is hypotension, raised JVP, and muffled heart sounds. We all know that. Investigation, remember for tension pneumothorax, it has to be clinical examination. Rest you can see in open, you have the chest X-ray with after patching the chest wound. Flail chest is also chest X-ray. Remember for pericardial tamponade, it is EFAS that we prefer now. For emergency, you do a needle thoracocentesis. Where do you insert the needle? In pneumothorax. Remember, tension pneumothorax, open pneumothorax. If it is a child, it is second intercostal space, mid-clavicular. Adult, fifth intercostal space in the mid-axillary line. On the other hand, where do you put the ICD? It is going to be in the safety triangle. What is the safety triangle? Anteriorly by pectoralis major, posteriorly by latissimus dorsi, inferiorly by sixth rib. In the fifth intercostal space, anterior to mid-axillary line is where you're going to place it. This is the position where you're going to put across here, right? Now, in your flail chest, we try to do an adequate analgesia. If that does not work, do an intermittent positive ventilation, that is intubate the patient. Whereas in terms of your pericardial tamponade, do a pericardiotomy, identify the site where you want to evaluate it, and wherever the leak is happening or the bleeding is happening, take the tie and just close it across, right? So this is with respect to your all four disorders that you have to take into consideration. Okay, chalo. Now, these are the images that they'll ask you a spotter. This is our tension pneumothorax will look like. Air on one side, collapsed lung, trachea divided opposite side. Flail chest, more than or equal to two continuous ribs fractured, more than or equal to two different sides on the same rib. This is your pericardial tamponade where the heart is enlarged. It looks like a water bottle stomach, widening of the cardiac shell out. And the CT, that is the cardiothoracic ratio, is going to be more than 0.5. And this indicates a pericardial tamponade also. It can be seen in pericardial effusion also, but not very important. One thing that I'm expecting this year in INICET is to get you these. What are these? These are rib plates in order to fix the fractures. Remember, red color rib plates is right-sided. R for red, R for right. Blue colored rib plates are for left-sided. That is what the exam question is going to be. They'll ask you that what is the color code of these rib fixation plates. Red is for right, blue is for left. If there is a bouncer which is golden in color, it is universal. That means it can be used in both left and right. I repeat again, if it is a red colored plate, it is for right side. If it's a blue colored plate, it is for left side. If it is golden color plate, it is universal. It is going to be for both of them. You can see here, I've used a golden color plates, which is going to be a universal plating system. All right. So this is another anticipated exam question. Now, going on to the next question that we have. All right. Now, I have a 37-year-old unmarried nulliparous female having a regular intercourse, right? She is on oral contraceptive pills. Okay, her mother was diagnosed at the age, breast cancer at the age of 60 years. Fine. Sister diagnosed with carcinoma ovary at 40 years of age, right? So the elder sister was diagnosed with carcinoma of ovary at the age of 40 years. What is the next line of management? Now you can see there's a family history of the breast and ovarian cancer both. So I can say this is a candidate that we're looking at HBOC syndrome. This is a candidate who is having an HBOC syndrome. An HBOC syndrome is your hereditary breast ovarian cancer syndrome. It's a hereditary breast ovarian cancer syndrome, right? We say HBOC syndrome, which is a hereditary breast ovarian cancer syndrome. So what do you do in HBOC syndrome? Now, any patient who's suspected to have an HBOC syndrome, I've given an example of 40-year-old female with breast cancer. On mutation, it is found to be positive. Let's say we have tested the patient for BRCA mutation. So what are you doing the next immediate step? Any female who is having a history of family history of breast cancer, we're sending for BRCA mutation testing. If it is positive, we're going to screen all positive related with BRCA mutation. If the family member is positive, we'll see whether the family status is complete or incomplete. If the family status is complete, we'll do a risk reduction strategy. If it is incomplete, I'll see the age of presentation. What is the risk reduction? Remove both the breasts, both the ovaries, that is bilateral salpingo-oophorectomy and bilateral prophylactic mastectomy. If patient is unwilling for surgery, I will go with selective estrogen receptor modulators, example like tamoxifen. Now, if the age of presentation, and family status is incomplete, age is less than 25, do nothing. Let her live her life, ask her to come back when she turns 25. After the age of 25, do an MRI, that is annual MRI as a screening protocol. Remember, the investigation of choice to screen breast cancer in high-risk population is MRI, and that is what we're trying to tell you here also. So, what are you going to do as the next step? Now, genetic counseling and screening of BRCA, yes, this is what I would like to do it. Mammography routine, no, she's a high-risk patient. In a high-risk patient, I would perform MRI as the investigation of choice for screening. Investigational choice for screening in high risk population. In high risk population, right? See, OCPs, again, I've told you again and again in my class, OCPs are not a risk factor for breast cancer. They do not increase it, so hence OCP does not make a big difference about it. Prophylactic surgery, unless you do not have BRCA mutation being positive, you have not established a BRCA mutation, you cannot go with prophylactic surgery. Is this question clear, right? This appears to be a very small and easy question, but every single time they ask you a question with the options, they'll keep taking up. That is why I try to eliminate each individual option on its merit. Is it clear? Okay, chalo, great. Going on to the next question. Which of the following does not come under the breast cancer classification under T4B, right? Now, what is T4B? T4B is involvement of the chest wall, right? Sorry, skin. T4B is involvement of the skin. So T4A is any size if it is involving the chest wall. T4B is involvement of the skin. But how do you know that the skin is getting involved? How do you know the skin is getting involved? Now, the first thing, number one, there will be presence of Peyote orange. Number one, there will be presence of Peyote orange. Number two, there will be presence of ulceration. And number three, there will be presence of satellite nodule. Presence of satellite nodule. This is how you know the skin is getting involved, right? Then you have T4C, which is going to be A plus B, both skin and the chest wall. And T4D is going to be inflammatory breast cancer. It is an inflammatory breast cancer. The criteria for an inflammatory breast cancer is more than 1/3 of the breast skin should be involved in inflammation. More than 1/3 of the breast skin, more than 1/3 of the breast skin must be involved. It must be involved in inflammatory component, right? So here, which of the following is not, right? Which of the following is not? Let's look at it. Does ulceration continue? Yes. Erythema less more than 1/3 is inflammatory breast cancer. It will become as T4D, right? Peyote orange, yes. Satellite nodule, yes. So answer here is going to be B for Bombay, right? Most of you given me a right answer. Absolutely correct. Remember, so it is going to be B for Bombay, which does not come under T4B disease, right? Now, this is what we've been talking about every single class that we have on breast. This is how you remember the TNM classification. T1 less than or equal to 2 centimeters, T2 is 2 to 5 centimeters, T3 is more than 5 centimeters. Now, T4A, any size which is going to involve the chest wall. Chest wall is made up of what? Ribs, intercostal muscles, and the serratus anterior group of muscle. What is T4B? Any size involving the skin. T4C is both skin and the chest wall. T4D is your inflammatory breast cancer, where it is involving more than 1/3 of the breast skin is involved. Lymph node status, again, if N1 axillary node which is involved, which is going to be absolutely mobile, where is our N1? It's here. Absolutely mobile, single node. N2A, all the lymph nodes in the axilla gets fused and matted. N2B is involvement of internal mammary group of lymph nodes. What is N3A? Involvement of infraclavicular. What is N3B? It is both, that is internal mammary as well as the axillary group. What is N3C? It is supraclavicular. That's how it is, right? M0, no evidence. M1, there's evidence of distant metastasis, and this is how you look across it. Now I'm going to tell you an easy way to remember the TNM classification. Based upon the TNM, you have the entire staging protocol. You have to remember what is stage 1, 2A, 2B, 3A, 3B, 3C, and these are the prospects which are present. Forget about all that. Just remember this. Your magic words. N2 is equal to 3A. N2 disease is a 3A stage. T4 is your 3B disease. If it is an N3, it's a 3C disease. If you remember this, all your questions on your breast staging can be, just wipe it off, right? Remember again, if you see an N2 disease in the question, it is 3A. If you have a T4, T4 is bigger than N2, right? So it is bigger than 3B disease. If you see N3, which is the biggest, it is a 3C disease. If you remember this, your job in the TNM of the breast is done. You don't need to worry about it. Okay? Chalo. So this is, one second, suddenly it is misbehaved. Okay. Going on to question number 9, right? Look at the question. Which of the following the image shown is of Z-Plasty procedure on the skin? What is the main use of this surgical technique? Right? Answer the question. I'll just get water. What is the main use of this technique? Okay. All right, what is the main use of this technique? When you talk about Z-Plasty, usually we prefer doing a Z-Plasty whenever you have a wound contracture, right? Now imagine that this is the arm of the patient. Patient was burning crackers in Diwali. Because of that, there's a wound contracture. The burn has occurred. After the burn has occurred, the wound contracture has now developed on this forearm, right? So this is how the wound contracture is going to look like. This is how the wound contracture is going to look like, right? Now, because of wound contracture, the patient is not able to extend the arm. So what I'm going to do, I'm going to do Z-Plasty. So how are you going to perform a Z-Plasty? So what we do is, let's say this is the contracture that is present. Let's say this is the wound contracture that is present. I have to release this wound contracture. My job is now to release this wound contracture, right? I have to release this wound contracture. So what I'll do is, I will mark 2 points. This is point A, this is your point B. Between point A and point B will be my first incision, right? Now, after putting the incision here, I will mark another point which is called as point C, which is here, and a point D, which is here. I will extend from A to C, and I'll extend the incision from B to D, right? Now, once you do this, what is going to happen? Now, this area of the skin is now going to be excised. You see that this area of the skin is now getting excised. You see this area of the skin is now going to get excised. Okay? All that you have to do is hold point C, point D and pull it. So what is going to happen? The wound is now going to relieve its contracture. Now this release depends upon the angle that you're going to use it in Z-Plasty, right? Now what you can do is you can continue to build it. So from here you can point it as point E, you can mark it as here, you can mark it as point F, right? Then extend the incision between D to E and then between C to F. You can have the point here, which is point F, right? Again, it depends upon the angle in which you are going to do. So we'll continue to do that like a serial and then you pull it across. Now, if the angle is going to be at 30 degrees, there is increase in scar length by 25%. If the angle is going to be 45 degrees, then the increase in length is by 50%. If the angle is at 60 degrees, there is increase in length by 75%. And if the angle is at 90 degrees, there is increase in length by 100%. The ideal angle that we are going to use, the ideal angle that we are going to use in Z-Plasty, the ideal angle that we're going to use in Z-Plasty is going to be at a 60 degrees with an increase in length of 75%, right? So here, why did you do the Z-Plasty, right? Let's try to analyze the reason for doing a Z-Plasty. To increase the length of the scar, yes. It is not for flap turning, not for cosmetic camouflage, not for muscle release. It is to increase the length of the scar. Okay. So this is with respect to Z-Plasty. Sure. Go to the next question. Which of the following is not a contraindication? We're looking at not a contraindication for breast conservative surgery, right? Now remember, rather than trying to talk about the contraindication, let's talk about what is the indication for breast conservative surgery, right? So when I talk about what are the current indication, the indications for breast conservative surgery, right? What are the indications for breast conservative surgery? Number one, if the size of the tumor should be less than or equal to 4 centimeters. Number two, it should be limited. It should be limited to one quadrant. It should be solitary. It should be solitary. There should be no evidence of lymphovascular spread. There should be no evidence of lymphovascular spread, and there should be no contraindication. No contraindication for radiotherapy. That is your ionizing radiation. Now, usually when we say what are the contraindications for radiotherapy, two important ones that you have to remember. Number one is pregnancy. That is what is contraindicated in pregnancy. And number two, people with connective tissue disorders. The connective tissue disorder usually flares up on exposure to radiotherapy, right? So these are the indications for your breast conservative surgery. Let's apply this and see in our question. Now, which is not a contract. Scleroderma is a connective tissue disorder. So in a connective tissue disorder, I told you it is a contraindicated, right? So which of the following is not a contraindication, right? Which of the following is not a contraindication? Scleroderma is a contraindication. Previous radiation to chest wall, tumor limited to one quadrant. See, if the tumor is limited to one quadrant, I can give the breast conservative surgery. History of radiation to previous, chest wall. Obviously, if the chest wall is already irradiated, now giving a radiotherapy again becomes difficult here. Persistent positive margin after repeated excision. This is an indication for radiotherapy. I will give radiotherapy. Tumor limited to one quadrant. I will give radiotherapy. Radiation to the previous radiation to chest wall doesn't matter. I don't have a problem. I will give radiotherapy here also. Now, connective tissue scleroderma is actually a connective tissue disorder, so it is a contraindication for. This is a contraindication for radiotherapy. This is a contraindication for radiotherapy, right? Which the following is not a contraindication for a breast conservative surgery, right? So, okay, not a contraindication for BCS. Scleroderma is radiotherapy can be given. Tumor limited to one quadrant and the RT in the component. Okay. So, which is not a contraindication of the surgery. It is tumor limited to one particular quadrant. Okay. Answer here is C for Calcutta. Now, going on to the next question. Sorry. Okay, I have a 44-year-old female presented to the surgery OPD with the complaints of ulceration of the skin and inflammatory signs in rest breast. Okay. Nipple retraction was also noticed, bad sign. Okay. Patient was diagnosed with invasive ductal carcinoma in situ. So you have a patient with DCIS, right? So ductal carcinoma in situ. Identify the stage of the carcinoma, right? Okay. It's saying invasive also. Okay, complaint ulceration of the skin. Now, skin ulceration, when you have, we have already dealt with this. If you have a patient with skin ulceration, it will be your T4B disease. Inflammatory signs on the right breast, nipple is retracted, patient was diagnosed with invasive ductal carcinoma. See, unless it does not tell you that inflammation is involving more than 1/3, you are not going to do anything over than that. Okay? Now, what is the stage of the disease? Now, you remember, is it a 3B disease? Stage 3B kya hai? What is the 3B disease? You remember, I told you have N2, T4, N3 disease. This is your 3A, this is your 3B, and this is your 3C disease, right? This is your 3C disease, right? Now, it says that which identify the stage of the disease. I have a T4 disease, so it is still fitting in 3B. Okay? I have T4B also here, right? Now, stage 4 with node positivity, they have not mentioned anywhere about the nodes, so I cannot take this. This option is wrong. No metastasis, again, they have not told about it. We cannot talk about it. Now, in order to call it as stage 3B, you should have lymph node status as well as the metastasis status also, which they have not mentioned. So, this best option here is going to be C for Calcutta, right? Please do not mark it. This is a trick question, beta. Do not mark it as 3B because there is no lymph nodes which are mentioned. They're saying ulceration, everything is there, nipple retraction is there, patient diagnosed with invasive ductal cancer, identify the stage of the carcinoma of the patient. But then they have not mentioned about the lymph nodes. Lymph nodes are not mentioned and the status of metastasis is also not mentioned. Unless you don't have the lymph node and metastasis, you cannot comment upon the stage. Okay? Do not goof upon that. It is T4B disease. Now, let's look at the next question. Estimate the extent of the injury of the patient with burns involving the chest, abdomen, the right upper limb and the whole of the right thigh. Okay. So this is according to the Wallace rule. I hope everybody knows it. Nothing spectacular about the Wallace rule. We talk about the adult and the child in differentiation, right? So in the Wallace rule, we talk about adult and child. So we'll have the various components which are going to be present. Now, the first thing is going to be the head and neck. The head and neck in adult accounts for 9%, child it is going to be 18%. Then you have the upper limb. The upper limb in adult is 9%, the child is also 9%. Then you have the anterior trunk. Whenever you say the word trunk, it is chest plus abdomen. If it is anterior, if it is posterior, then it is only going to be back. So trunk here is going to be 18% each. Then you have the posterior trunk. The posterior trunk is also 18% each. Perineum. In adult, it is 1%. Child, it is non-existent. Then you have last is going to be lower limb. Adult is going to be 18% each. This is 14% each, right? Now remember, child according to ATLS is age less than 14 years. Age more than 14 years will be considered as adult, right? Now he's asking the estimate the extent of the injury for a patient with burns involving the chest and the abdomen. The chest and the abdomen is your anterior trunk, so we have 18%. Okay, right upper limb completely, so I'll say another 9%, right? And the whole of the right thigh. So here he's not doing entire lower limb, only the right thigh is involved. So when I say right thigh, it is going to be half of it, right? It is going to be another 9%. So you have chest and abdomen together is 18%. 18 plus 9% is upper limb. The whole of thigh is again half of the upper limb. It is 9 to total is of 36%. This is the 36%. So this is your answer is C for Calcutta. It is a 36%. Okay, chalo. Now, open cardiac massage. The numbering is slightly wrong, so I'm just erasing it. Open cardiac massage is what kind of a wound, which is according to the wound classification of the surgical wound. Surgical wound classification. You have clean, contaminated, dirty. So let's quickly look at it. What is clean wound? The criteria for clean wound. The criteria for clean wound. Number one, it should be an elective surgery. It should be elective. It should be non-traumatic. And there should be no entry into natural cavity. No entry into natural cavity. This is clean, right? Open cardiac massage is basically a patient who has underwent, let's say, any open heart surgery, and then there is some issue, you're re-exploring it. So open cardiac massage is usually for re-exploration, as simple as that, right? Now, when I say contaminated wounds, now the criteria for contaminated wounds are going to be all your emergency surgeries, traumatic wounds, your traumatic wounds, and all your re-explorations will be contaminated. Dirty if it consists of pus or fecal matter. If it consists of pus or fecal matter, this is going to be your dirty. What is clean contaminated? The clean contaminated is an extension of clean wounds. It has to be elective surgery. It should be non-traumatic. But entry into the natural cavity is allowed. Entry into natural cavity is going to be allowed, right? Now, when you look at this, open cardiac massage is a re-exploration, and re-exploration will belong to contaminated wounds, and this was your previous exam question. This is going to be a previous exam question. So when you come here, these are the examples that you have. For a clean wound, I said non-traumatic, elective, no entry into nasal cavity. All your lipoma, excision, thyroidectomy, paratectomy, mastectomy, brain surgery, joint surgery, heart surgery, all of them are clean surgeries. Clean contaminated is non-traumatic, elective, no entry into nasal cavity. Entry into nasal cavity under a controlled environment. This clean. In clean, there is no entry into nasal cavity. In clean contaminated, entry under controlled environment. All your elective bowel surgeries are going to be your clean contaminated. Incontaminated, traumatic, emergency, re-exploration, uncontrolled bowel spillage during surgery. Example like open fracture, open cardiac massage, hollow viscous perforation, bowel obstruction, all these are clean contaminated. Dirty wounds are one with fecal and purulent status. Okay, that's how simple it is. Clear? Now, going on to the next question. Okay. So what do you have? I have a female with a non-palpable lump in the breast. The biopsy and the IHC reveals luminal A. What is included in luminal A? Now, when you talk about luminal A, so all these are going to be evaluated on estrogen receptor, the progesterone receptor, HER2 neogene status, and also there is something called as the Ki67, which is a proliferative index. You have Ki67, which is a proliferative index. Now, for a luminal A criteria, for a luminal A, ER/PR is positive, HER2 neogene is negative, and Ki67 index is low, right? This is your luminal A. So, find out where do you find it. ER positive, PR positive, HER2 positive, this is wrong. ER positive, PR positive, HER2 negative with low proliferative index, yes, correct. ER positive, PR positive, HER2 negative, but high proliferative index, no. Triple negative, no. So, answer here is B for Bombay. It is going to be B for Bombay. That is your luminal A. If I talk about luminal B is going to be all three of them are positive. It is called as triple positive, right? Then you have basal cell type, where all three of them are negative. There's triple negative. And the last one that you have is your HER2 neogene type, which you have HER2 exclusive, right? So only HER2 neogene is positive, the other two are negative, right? So, okay, wait. This is your basal cell type, right? Now, if we talk about HER2 neotype, these two are negative, only HER2 neogene is positive, right? So this is with respect to HER2 neotype. This is your luminal A variety, which is going to be B for Bombay. Now, this is again a very common sense question, but this is asked in our last exam also. Temperature for a frost bite rewarming is needed to be at what temperature? Whatever is above your body temperature, right? What is your body temperature? 37 degrees Celsius. What is above your body temperature will allow the frostbite to defrost it, right? So obviously, the first two options you can eliminate, 20 and 24. Now, 38 degrees and 42. 38 degrees is not hot enough to basically defrost it. So the best answer here is going to be 42 degrees Celsius. It is going to be at 42 degrees Celsius, right? So this is for frostbite rewarming. It is your frostbite rewarming. Next. Now this is also repeatedly asked exam question. During a parotid surgery, which is the following would not be a surgical landmark for identification of the facial nerve, right? Now, remember, the posterior belly of digastric actually traces the trunk of the facial nerve. What is a tragal pointer? Tragal pointer is 1 to 1.5 centimeters medial and below. Medial and below the tip of tragal cartilage is what we call as tragal pointer. This also points towards the trunk of the facial nerve. Inferior belly of the omohyoid, again you trace it, you will reach to the trunk of the facial nerve. Dissection of the peripheral branches won't help you at all. So answer here is going to be D for Delhi. It is going to be D for Delhi. So what are the other surgical landmarks to be remembered? Number one, if you follow the tympanomastoid suture line, the tragal pointer we have discussed it, the posterior belly of the digastric, the retromandibular vein, and the styloid process of your temporal bone. One more that we have already, inferior belly of omohyoid also. inferior belly of the omohyoid as well, right? So these are the surgical landmarks which are going to tell you about the trunk of the facial nerve. We're asking not. All the other three are. The one which is not is going to be dissection from the peripheral branches. So, going on to the next question. All right. Our 32-year-old female with Graves' disease, with eye signs and enlarged thyroid, planned for total thyroidectomy, right? What can be given pre-operatively to reduce the intraoperative bleeding in the patient? This is again a repeat exam question. We'll quickly run through it. Now, normally when you talk about the whole thyroid gland status, this is the follicle. On the follicle, you have the sodium iodine symporter. You have the sodium iodine symporter. Within the follicles, we have thyroperoxidase enzyme. This will release the thyroid hormone into circulation. So there are hormones which are releasing into the circulation. And whenever required, there is something called as peripheral conversion, which is going to occur inside the liver or skeletal muscles, other side, where the T4 gets converted into T3 whenever is required, right? So when you talk about the antithyroid drugs, the first one is a sodium iodine symporter blocker. These are your perchlorate and thiocyanate. And the thiocyanate, both of them are extremely toxic, they're withdrawn out of the market. Then there are drugs which inhibit the thyroperoxidase enzyme. Drug that inhibit the thyroperoxidase enzyme are your propyl thiouracil and carbimazole. Then you have drugs that inhibit the secretion, right, into the circulation. These are your sodium iodide, your potassium iodide, and your Lugol's iodine. Remember, they have additional property. They reduce the vascularity of the gland. They reduce the vascularity of gland. And the last drug that you have, which inhibits the peripheral conversion. Drug that inhibit the peripheral conversion are, number one, it is your propyl thiouracil. Number two, propranolol. And a steroid, that is a prednisolone. So these are the drugs that inhibit the peripheral conversion also. Right? So this is the whole objective. Now, in order to reduce the I want the intraoperative bleeding to become less. So I have to reduce the vascularity of the gland. So which drug reduces the vascularity? We have already read it. It is a sodium iodide, potassium iodide, Lugol's iodine. Fine, where is you have potassium iodide is here. Answer is here. It is not propranolol, not propyl thiouracil, not betamethasone. In fact, all three of them actually inhibits the peripheral conversion. Right? All three of them inhibits the peripheral conversion, which is safest in pregnancy. Remember, P for propyl thiouracil, and it is safe in pregnancy. An antithyroid drug which is safe in pregnancy is your propyl thiouracil, right? So this is with respect to this question. Going to the next one. So which of the following is not, this is a repeat question, but with a different twist we have. Not a relative contraindication for breast conservative surgery, right? So the first contraindication for breast conservative surgery, size more than 4 centimeters, more than one quadrant, more than one lesion, if it is having a lymphovascular spread, or if there is a contraindication for radiotherapy. Now, tumor size less than 4 centimeters, I can perform, and N1 metastasis. Now, N1, usually when we say there's a lymphovascular spread, we would not like to do it, but N1, that is single lymph node in the axilla, which is mobile, it can be addressed with sentinel lymph node biopsy, so I can still put it as question mark here. Tumor size, tumor more than the size of the breast, there's an you cannot do. How will you save the breast? Breast conservative surgery is to remove. What is a breast conservative surgery? It is basically to remove, it's like a wide local excision with radiotherapy. It's called as breast conservative surgery. Now, if the tumor is bigger than the breast, there's no point saving the breast. Prior chest radiation, again, it is becoming resistant. I can't give radiotherapy here. Multicentric tumors also I cannot do a breast conservative surgery. So answer here is, that is why saying relative contraindication, right? So answer is, which is not a relative contraindication, it is option A, size less than 4 centimeters with N1 disease, which is relatively not a contraindication. Now, which of the following is not a part, there are a lot of not questions in INI, not a part of damage control surgery, right? Now, damage control surgery comes in stages, right? What is the stage 1 of damage control surgery? It is your patient selection. You should know which patient will require a damage control surgery and which will require an early total care, which is called ETC. Stage 2, it is primary exploration. Now, what is the goal for primary exploration? Whenever you're doing a primary exploration, the goal is very simple. It is control hemorrhage, prevent further contamination, prevent further contamination, prevent further contamination, and temporary abdominal closure. And temporary abdominal closure. Then you go to stage 3. Stage 3 is your ICU care. That is going to be for 24 to 48 hours. In an ICU care, what do you do? Correct coagulopathy, and treat hypothermia. After 48 hours, we'll go to stage 4, which is your secondary exploration. So what do you do in secondary exploration? It is to correct the anatomy. The last one is your definitive abdominal closure. Stage 5 is your definitive abdominal closure. Those are definitive abdominal closure. Which of the following is not a part of damage control surgery or damage control protocols? Okay, let's look at this, right? Now, control hemorrhage, yes. Resuscitation, yes. Decontamination, yes. We are not going to look for any anastomosis in the initial part. We are just trying to do a controlled component. So vascular anastomosis is not a component. We'll ligate the vessel and come back, right? So control, resuscitate and decontaminate. Okay. So patient selection, clear. So decontamination is this only, no? To prevent any further contamination. This is called as decontamination. Okay. Chalo. Can you move on? Chalo. Going on to the next question. Mastectomy was done in a patient and the following drain was kept under the flap. The flap needs to be, now this is a drain which is, you can identify in the image, this is your Romo-Vac drain. It works on the principle of negative suction pressure. So it is an active drain. This is an active drain, works on negative suction pressure. Works on the negative suction pressure, right? So active drain, it's a negative suction pressure. For negative suction, you have to make sure the wound is sealed, right? Now, what are they asking? The flap must be, it should be closed, not semi-closed, not open, not semi-open. It has to be closed so that I can maintain that negative pressure so that everything can accumulate it, right? Max to max, they'll ask you drain removal period. The drain removal in mastectomy is either after 5 days or if it is less than 25 ml in 24 hours. If the collection is less than 25 ml in 24 hours, whichever is that. If it is more than 5 days or the collection has become less than 25, we have to put 5 days. But if let's say if it is beyond 5th day and you have a collection less than 25, then also you can remove it. Right? So there are the two criteria of drain removal period. Right? Going on to the next question. A patient had a tibia fracture 1 month ago. His cast was removed. Few ecchymoses were observed on the skin. Few days he came back with the pain while lifting his great toe. Okay. There was also decreased sensation in the first web space. Both posterior tibial and dorsalis medius pulses were felt. What is the next step that you would like to do? See, all these patients are prone for something called as a compartment syndrome. They're prone for compartment syndrome. So I have to rule out the compartment syndrome. So what is the criteria for compartment syndrome, right? Post fracture, they've put an encased in that format. Okay? But a ICD removal criteria is very, very simple. Number one, if the column movement stops with a complete expansion of lung on an X-ray, that's the first important finding. Second, you see the collection that is present is significantly lower. It is less than 70 ml in 24 hours. Okay. The criteria for compartment syndrome is the compartment pressure if it is more than or equal to 30 millimeters of mercury with signs and symptoms of neurovascular compression. Signs and symptoms of neurovascular compression. This is what we call as compartment syndrome, right? Okay, so what will be the next step? A test, it is not for DIC. Why? There's no point of disseminated intravascular coagulation, right? Venous Doppler, no, I'm not looking for DVT. Measure the compartment pressure, yes. Admit the patient, given animal, no. Answer is C for Calcutta. See, if you're talking about the deep vein thrombosis, then the patient will have congestion in calf, pain in calf, there will be pain on passive dorsiflexion, low-grade fever, all these will be there, right? But here it is probably because of the compartment syndrome. Measure the anterior compartmental pressure. Okay, this is a repeat exam question. What does triage mean? It is a color coding system to categorize the patients on the basis of the outcome, and this is called as categorizing the patient. To categorize means to basically sort out. It is to sort out. So answer here is B for Bombay. So what is the criteria for triage? If they ask you what is the criteria for triage, remember it is done on the basis of outcome over severity. On the basis of outcome over severity. It is to sort out. It is segregate based upon the priority. No? This is your triage. Going on to the next question. What do you have? I have a 23-year-old male presents to the accident and emergency department with burns. Okay. From bursting of a stove. After initial resuscitation, patient is examined thoroughly. On examining the burns on his face. Now, there is burn on his face, which is accounting for, let's say, 9%. Also covering the whole of the chest and abdomen, that is anterior trunk. So say 80 is your anterior trunk, I'm saying 18%. The front of both the upper arms, the whole arm is 9%. The front only will become 4.5. Both is going to be 9. So upper limb together is going to be 9%. Right? What would the total percentage? Again, the total percentage is going to be 36%. It is going to be a 36%. So, going on to the next question. A 51-year-old female brought to the emergency department in an unconscious status after a road traffic accident. She is afebrile, okay, has a blood pressure of 60/40, which is quite low, pulse rate of 97 beats per minute, respiratory rate of 10 breaths per minute. Her GCS is 9/15. Her examination revealed multiple injuries and massive blood loss from a deep cut in the right upper quadrant of the abdomen, okay, suggesting of trauma to vital organ. The fast is done. The fast, which of the following can be evaluated? Now remember, fast is useless for less than 100 ml. Minimum fluid required. Minimum fluid required The minimum fluid required for fast to be positive. For fast to be positive is 100 cc. The minimum fluid required for the fast to be positive is 100 cc, right? Uh, Retroperitoneal organs, again, ultrasound is a poor modality. Stomach injuries is hollow viscous. Again, I'll not be able to understand with the ultrasound. Solid organ injuries, intra-abdominal are the best. So answer here is going to be D for Delhi. That is your liver injuries. Which of the following can be evaluated? It is the liver injury that can be evaluated, right? That can be evaluated. So answer here is going to be D for Delhi. Now, which of the following are all of the following are included in ATLS primary survey except. Now we talk about the surveys. No, there are three surveys that we do. We do primary survey, we do secondary survey, we do tertiary survey. Primary survey, it is to rule out any immediate life-threatening injury and any immediate life-threatening injury. This has to be fast, quick, easily available and accessible. Secondary survey is done to rule out any potentially life-threatening injury. So there are detailed evaluation here. Potentially life-threatening injury. Potentially life-threatening injury. Tertiary is a detailed examination. It's a detailed examination from head to toe. From head to toe to prevent any long-term complications. To prevent any long-term complications, right? Now here, which of the following, all of the following are done except, I will do a pelvic x-ray, I will do a fast, I will do a chest x-ray. Pelvic x-rays are done to evaluate for pelvic fractures. We all know it's one of the most important cause for your blood loss, which is occult. Also, fast is done to evaluate for your blunt trauma abdomen as well as thoracic injuries. Chest x-ray, obviously to rule out the tension pneumothorax, your hemothorax, pericardial tamponade. Chest x-ray plays an important role. I would not do a CT in a primary survey. So answer here is D for Delhi. Okay, it is going to be D for Delhi. Clear? So far, any questions? Quick feedback, guys. Any questions? Can you move on? Sure. All right. Somebody saying both upper arm. Both upper arm for what, beta? Beta, both upper arm, only the anterior surface, right? So the upper arm, okay. Do not, if they say the word forearm, this is different. The whole arm is this. Okay, so don't get goofed up on that. Chalo. Moving on to the next question that we have. During a laparoscopic cholecystectomy, hepatocystic triangle is identified. Which of the following is not a boundary of the hepatocystic triangle? Now, there are two triangles. One is a Calix triangle, another one is a hepatocystic triangle. Please do not goof up between both of them. When I say this is a representation of the liver, and let's say this happens to be the left hepatic duct, this is the right hepatic duct, this is the common hepatic duct, this is the cystic duct, this happens to be gallbladder, and this is your common bile duct. The blood supply is going to be your cystic artery, which is going to be coming across it. Let's say this is how the cystic artery is going to supply the blood. Now, if I label it, this is your left hepatic duct, this happens to be your right hepatic duct, this is your common hepatic duct, this is your common bile duct, this is your cystic duct, and this is your inferior surface of the liver, right? Now, when you evaluate, there's a triangular area which is present between the cystic artery, the cystic duct, and the common hepatic duct. This is what we call it as the Calix triangle. This is what we call it as the Calix triangle, right? Now, within the calyx triangle, you see a lymph node that is called as the lymph node of Luminal. What is a hepatocystic triangle? Now, the same triangle, if I extend from the inferior surface of the liver to these boundaries, this triangular portion, right? This bigger triangle that you see between the common hepatic duct, the cystic duct, and at the inferior surface of the liver, this bigger triangle is what we call it as the hepatocystic triangle. In the hepatocystic triangle, what are the content or the boundaries? Number one, it is the inferior border of the liver. It is the inferior border of liver. Second, the common hepatic duct. Third, it is the cystic duct. If they ask you the content here is going to be the cystic artery. Calyx triangle, it is formed by number one, the common hepatic duct, cystic artery, and the cystic duct. This is your boundaries of Calyx triangle, right? Now here asking which is not a boundary. They're asking which of the following is not a boundary. When I say not a boundary, inferior edge of the liver is a boundary, cystic duct is a boundary, cystic artery is not a boundary, common hepatic duct is yes. Answer here is C for Calcutta. It is C for Calcutta. Clear? Just hold on for a second, guys. All right, guys. Now going to the next question. This was also a previous exam question. Identify the investigation which is given in the image. Now this is what we call as defecography, right? Again, it is not a barium swallow because barium swallow is for esophagus, right? And with no means it looks like an esophagus, right? You can see it looks like a rectum and the anal component. It is an X-ray defecography. It is not an MRI image. It is not a CT image. It is quite evident. Answer here is B for Bombay. It is a B for Bombay. Next question. Okay, which of the following options are wrongly matched? Okay, colon cancer. We all know the colon cancer. If you are going to talk about the criteria, it is going to be Amsterdam. Is the Amsterdam or the modified Amsterdam's criteria? What is this Boston score? Boston score is for bowel preparation. It is for the bowel preparation. So hence this is wrongly matched. Your answer A is correct, right? Parathyroid hormone, it is Miami criteria. I hope everybody knows what is Miami criteria. We do it for primary hyperparathyroidism when you are resecting it. So we measure pre-operative parathyroid hormone level. So we measure pre-operative parathyroid hormone level. And then we measure intraoperatively. Then we measure intraoperative parathyroid hormone level after removing pathology. After removing the pathology. Now, this intraoperative parathyroid hormone level that we are going to measure at 5-minute mark, at 10-minute mark, and at 30-minute mark. Criteria says that when you measure at the 10-minute mark, it should reduce. So parathyroid hormone should be reduced by more than 50% of preoperative value. Of the preoperative value. If it is satisfied, we say the Miami criteria is satisfied. And if the Miami criteria is satisfied, that indicates that you have removed the correct gland. Beta, if you can't rule out between X-ray and MRI, then it's difficult, no? Yeah? MRI imaging, you will see the whole component. Again, T1 versus T2 weighted will be there, right? Fat and water can be visualized. You see the muscle components are clearly laid out in MRI. You know? Sure. For GRD, it is Los Angeles criteria, which is also correct. For chronic pancreatitis, it's M and INICET is also correct. Okay? So answer here is A for Ahmedabad. A 38-year-old female with the complaints of swelling in the right lower abdomen, which reduces on applying pressure from the hand. Which of the following is the most common hernia in females? Again, please do not fall for this classical trap. Males or females, both of them, the most common hernia in both males and females. With moles in both males and females is your indirect inguinal hernia. It is your indirect inguinal hernia. This is going to be your indirect inguinal hernia. It is not direct. It is going to be indirect, not femoral, not operator. Answer is indirect inguinal hernia. Yes, femoral hernia is more common in females, but overall most common in females is also going to be your indirect inguinal hernia. Okay. I have a 44-year-old female presents with recurrent episodes of right flank pain with hematuria. Okay. History of prior episodes of UTI is present. Okay, perfect. Patient complains of severe lumbar region pain. Urine analysis says alkaline urine, pH of 8. Microscopy is given following, which is the most common condition. This image, if you're able to see, it's a coffin lid. The minute I say coffin lid, I know it is your phosphate stones. This is your coffin lid crystals. Now, this coffin lid crystals is your phosphate stone. It is your phosphate stone. The cause for the phosphate stone. The cause for the phosphate stone. It is a protease infection, which is a urease producing bacteria. Now, as urease is produced, it converts urine to ammonia. Ammonia concentration in urine increases. Urine becomes alkaline. So that's the reason, right? The phosphate stones are also known as, they are known as number one, triple stone. They're known as the triple stone. They're known as the struvite stone. They're also known as staghorn calculi. So triple, struvite, staghorn calculi are the other names, right? So answer here is going to be your triple phosphate stone, not calcium oxalate. See, if you have calcium oxalate stones, then you have envelope shaped crystals. It will have envelope shaped crystals. Uric acid will have multi-faced. They have multi-faced crystals. Cystine stones will have hexagon shaped crystals. It is hexagon or also called as benzene shaped crystals. We call it as hexagon shaped crystals, or they also have benzene shaped crystals. Okay. So this is with respect to coffin lid crystals. Now, going on to the next question. Our 22-year-old chronic alcoholic presents with severe hematemesis. Ultrasound shows distended portal vein and the liver appears to be hyperechoic. That means it is cirrhotic already. Pantoprazole has been initiated. What is the next step in the management? It is for your portal hypertension. The patient has bleeding from esophageal varices, right? There is no role for antibiotic here, so strike this off. There is no role for biopsy here. Again, strike it off. Yes, the patient is having volume loss, so I would like to replace it. I'll only do endoscopy once I control the bleeding. So the order is always resuscitate, start the patient on octreotide or terlipressin, and then switch to your sorry, then go and do a lavage, and after doing a lavage you do an endoscopy. So endoscopy comes late, so answer here is going to be C for Calcutta. Now those who are wondering what is the protocol that I'm talking about, for all bleeding esophageal varices, there's a stepwise protocol. The step number 1, it is to secure 2 large IV cannula and resuscitate. Start the patient on IV fluids. Second, to stop the bleeding, because you have IV line, you can give injections of octreotide or injections of terlipressin. Both of them now, both of them are somatostatin analog, they control the bleed. Now, if the bleeding is stopped, if bleeding stops, then you proceed for step number 3 is going to be your gastric lavage. Your gastric lavage. If bleeding still persists, if the bleeding still persists, then I will do an Sangastian Blackmore tube. That is a balloon tamponade with the tubes. It was Sangastian Blackmore tube. It's called as balloon tamponade effect. Now this SBT tube will stop the bleeding. There are 2 balloons in it. One is your gastric balloon. I will inflate 300 ml of air to inflate the balloon. And then you have the esophageal balloon. Where we inflate with 40 millimeters of mercury. So pressure which we are going to put is going to be your 40 millimeters of mercury, right? Beta, ringer lactate is preferred over normal saline for resuscitation for volume loss. Now, once you've done the bleeding is stopped, eventually after doing an SBT, you will come back to gastric lavage. After doing a gastric lavage, you do an upper GI endoscopy. Once you identify the varices, you do an endoscopic variceal ligation. If EVL fails, the last one, if EVL fails, then you do a shunt surgery. That is example like TIPS. The other shunts are transvalular intrahepatic portosystemic shunt. And the last one that you can do is, if it fails, is your liver transplant. This is the order that you have to follow in decision making in bleeding in portal hypertension. Okay. So this is a decision making chart for your portal hypertension. So, so here it is start the patient on IV fluids and electrolyte replacement. Okay, which of the following is not a risk factor for gallbladder carcinoma? Porcelain gallbladder, yes, it's a risk factor. It's a chronic calcified gallbladder. Primary sclerosing cholangitis, yes. Polyps of size more than 10 millimeters, not less than 10 millimeters, more than 10 millimeters, age more than 50 years, and gallbladder wall more than 4 millimeter in thickness. If all these are satisfied, yes, then it increases the risk. So C is the right answer. It is not the risk factor. Gallstones, especially more than 2 centimeters, they increase the risk. More than 2 centimeters, they increase the risk. So answer here is going to be C for Calcutta. It is going to be C for Calcutta. Now, the classification of the bile duct injury taking location and the thermal injury into the ducts and into the vessels account for. See, bismuth is for post-operative stricture. Strasbourg only consists of injury to bile duct, not to vessels. Injury to the bile duct. It is the Hanover that also considers the site and the component of vascular injury? So answer here is D for Delhi. It is going to be D for Delhi. So for any doubts, guys, quick feedback. Quick feedback. Somebody is asking Stewart way. But Stewart is also for bile duct injury only, but here we consider only two things: mechanism of injury and site of injury. It is the mechanism and the site of injury. If we're talking about the duct and vessel, then it is Hanover. Chalo, going to the next one. Post orchidectomy, the specimen shows, okay, this is a repeat question, that is Rannicus crystals. It is going to be for your Leydig cell tumor. It is going to be a Leydig cell tumor. Sorry, guys. Now, this is how the Rannicus crystals will look like. You can see there are these crystals which are present here. You can see these stained. These are eosinophilic clusters. Your pathology will tell you these are eosinophilic crystals or the clusters that develop. These are your Rannicus crystals. All right. Chalo. Now, patient underwent cholecystectomy. The histology reveals the carcinoma with invasiveness into the muscularis. Okay. What is the next best step? So, in the question or eosinophil viruses, if they give pantoprazole, why does it has? Okay, see pantoprazole. Okay. Basically, whenever you give a pantoprazole, it is a proton pump inhibitor. It is a hit and run drug which suppresses the acid secretion. It reduces the gastric irritation because the bleeding itself is causing a lot of gastric irritation. No? To reduce the gastric irritation, we give pantoprazole also. That's the only objective. Clear? Hai? Clear? Can you move on? Okay. Now, when you talk about the gallbladder cancer, let's look at the quick assessment of its TNM classification. Right? Let's say the innermost layer that you have is the mucosa. I hope everybody knows that there is no submucosa in gallbladder. So this is the mucosal layer that you have. Under the mucosal layer, you have the muscularis. So the muscularis in gallbladder is arranged in a crisscross fashion. The muscularis of the gallbladder, they are arranged in a crisscross fashion. And the outermost layer that you have is going to be the serosa. This is the outermost layer, that is serosa, right? So when you look at the innermost layer, this is mucosa. Then you have muscularis. And the last one that you have is your serosa. Now, we say if the tumor is limited to that of the mucosa, if it is limited to that of the mucosa, it is T1A. If it is involving the muscle and that to the inner half of the muscle, if it is involving the inner half of the muscle, if it is involving the inner half of the muscle, this is T1B. If it is involving the outer half of the muscle, if it is involving the outer half of the muscle, it is your T2 disease. If it is going and breaching the serosa, this is your T3 disease. This is your T3 disease, right? If it is going and breaching the serosa, it is your T3 disease. Now, if it is involving beyond serosa, so T4 is local invasion. T4 is considered to be as local invasion. Now this local invasion, so T3 is going to breach and go beyond serosa. This T2 is very important because it is going to be in subserosal space, right? So this T2 has two differentiation. So when you talk about T2 disease, has two differentiation, that is T2A and T2B. What is T2A and what is T2B? T2A, it is perimuscular connective tissue. So there's a layer of connective tissue which is present. The layer of connective tissue which is between the gallbladder and the serosa. This is called as perimuscular connective tissue, right? So in T2 disease, there is involvement of perimuscular connective tissue, right? So there is involvement of perimuscular connective tissue. Now that perimuscular connective tissue, if it is involved towards the peritoneal side, then it is T2A. If it is involved towards the hepatic side, that is the liver side, it is going to be T2B. It is going to be T2B, right? So now T3 is considered to be as beyond serosa. It is beyond serosa, which surrounding structures are involved. So when it goes beyond serosa, what all can it involve? It can involve stomach, it can involve duodenum, it can involve colon, pancreas, omentum, extrahepatic bile duct. Your extrahepatic bile duct. So these are the structures which can involve in T3 disease. T4 is a local invasion into number 1, portal vein, hepatic artery, or more than or equal to 2 extrahepatic organs. More than or equal to 2 extrahepatic organs. Right? So based upon this, you have your treatment protocol. So what is the treatment protocol? We say if a patient presents to you, we'll write the treatment protocol here. If a patient presents to you with T1A disease, we do a simple cholecystectomy. If a patient presents to you with T1B and a T2 disease, here we perform a radical cholecystectomy. Then you have a T3 disease and a T4 disease. For T3 and T4, we do a neoadjuvant chemotherapy. If it is having a good response, then I will do a radical cholecystectomy. But if it has a poor response, then we'll do a palliative management. This is the algorithm that we follow, right? Now, we are saying the histopathology reveals that there is involvement of the muscle. Involvement of the muscle indicates T2 disease, right? If there's a T2 disease, you can do a radical cholecystectomy. What is the next step? Not radio, not chemo, excision or some no. It is an extended cholecystectomy, also called as radical. When I say extended, what are you going to remove? You are going to remove segment 4B and the segment 5 of liver. This is what we call it as a extended cholecystectomy. So what did you extend into? The segment 4B and the segment 5 of the liver. The segment 4B and the segment 5 of the liver. That's the extension that you're looking for. Clear? Clear, guys? ठीक है? That is a gallbladder carcinoma. Now, let's go to the next question. I have a patient with dull aching pain in the tortuous vein of both the limbs. The following test can be used to check the competency of the saphenofemoral junction. Okay? Now, you have Fagan's test, you have Morrissey's test, you have the modified Perthes test and the Brody-Sternberg test, right? Now, Brody-Sternberg test, it is done to differentiate between saphenofemoral junction incompetency versus perforator incompetency. Versus the perforator incompetency. The modified Perthes test is to predict. It is to predict the history of DVT. Morris's is a cough impulse. This is a cough impulse. It is positive if the saphenofemoral junction is incompetent. Fagan's test is a crescentic defect. This is for perforator incompetency. This is for perforator incompetency. Now the question says, which of the following is done to evaluate for the incompetency? So, the competence is saphenofemoral junction. Now for saphenofemoral junction, I can do number 1 is your Morris's cough impulse test. Another one is your Brody-Sternberg. 2 and 4 is your answer. It is your A for Ahmedabad. Clear? Okay. Then there is something called as the 3 tourniquet test to know the level of perforator incompetency. To know the level of perforator incompetency. There is a Schwartz test, which is like, to know the valvular incompetency. You tap at one place. If the impulse is felt both up below and above, it is called as the positive Schwartz test. That is going to be for valve incompetencies, right? Sure. Going to the next question. A 6-year-old male child was admitted with acute liver failure. All of the following are included in King's College criteria except. Now, King's College criteria is for liver transplantation. We will divide them into with paracetamol toxicity and non-paracetamol toxicity. The criteria, if a patient is, see, the most common cause. Here's an interesting thing. The most common cause for liver transplantation in adults. In adults, it is your hepatitis C virus induced liver cirrhosis. Right? The second most common cause for liver transplantation in adults, it is alcohol induced. It is your alcohol induced liver cirrhosis. It is the alcohol induced liver cirrhosis. Beta, how are these tests performed? In order to know in detail, you have to watch our regular lectures. We don't have the enough amount of time and leverage to explain each individual test. We have a detailed explanation in our regular lectures as well, right? I would recommend you to go down and look at the varicose vein lecture. You'll find all the tests and their implications there. Now, the second most common cause for the liver transplantation in adults is going to be your alcohol-induced liver cirrhosis. The most common cause in children is because of extrahepatic biliary atresia. If I say what is the most common metabolic cause, it is your alpha-1 antitrypsin deficiency. If I say what is the most common emergency cause, the most common emergency cause is your paracetamol toxicity. The most common emergency cause. The most common emergency cause is your paracetamol toxicity. So these are the indications in general. Now, if it is because of paracetamol toxicity, the criteria is if the pH is less than 7 or any of the 3, right? That means if the INR is more than 6.5, creat is around 3.4, and if it is grade 3, grade 4 encephalopathy, right? If these are present, then you have to go with liver transplantation. For non-paracetamol toxicity, the pH, the INR is more than 6.5 with a PT of more than 100 or 3 out of the following 5. Number 1, the age should be less than 10 or greater than 40, right? So look at our first criteria, right? Age is less than 11, it is wrong, it should be less than 10. So it is gone. Second, it should be non-A, non-B hepatitis or idiosyncratic drug reaction. The duration of jaundice before the development of encephalopathy should be more than 7 days, right? So you should have 7 days of jaundice, right? Jaundice is less than 7 days, more development, no. The jaundice should be of more than 7 days, right? Before development of encephalopathy, this is also wrong. INR of more than 6.5 is actually correct. Bilirubin of more than 300. Now look at serum bilirubin is either more than 18 or 300 micromoles per liter, right? A PT of more than 50, INR of more than 3.5. So you're looking at these criteria, either INR of more than 6.5. If you're looking at this, then PT greater than 40, INR of more than 3.5 is given, right? So here, if you're looking at the other criteria, then this will go wrong. The bilirubin of more than 300 micromoles, that is correct. So answer here is going to be D for Delhi, right? So which of all of the following including King's College criteria except? If you look at, okay, I think answer which is not the criteria, just remove the except. Okay. Answer here is going to be bilirubin of more than 300 because rest all of them, age should be less than 10, jaundice should be more than 7 days, INR should be more than 3.5, bilirubin of more than 300 is correct. Chalo. This again is a repeat exam question. This is a spotter from the image. What is the most probable diagnosis? What is the answer, guys? What is the most probable diagnosis? Quick feedback. What is the most probable diagnosis? The most probable diagnosis. This is of cholesterol, I mean say crystals, which is nothing but strawberry gallbladder. Hai na? So this condition that you see here is a classical strawberry gallbladder. So we call it as the cholesterosis. We have cholesterolosis. It is a cholesterolosis. Cholesterolosis. It is simple words. It's called a strawberry gallbladder. This is your strawberry gallbladder. Now talk about strawberry gallbladder. It is nothing but accumulation of lipids. It is because of accumulation of lipids. So when I say lipids, what am I talking about? Number one, triglycerides. Number one is triglycerides. Number two is cholesterol precursors. And number three is your cholesterol ester. Now, they are usually less than 1 millimeter in size. They are usually less than 1 millimeter in size. The lipid deposit appears to be yellow. Gives you a classical yellow color. So what happens? No, this lipid deposit will give you yellow color. The mucosa is red in color, no, so it gives a classical strawberry appearance, right? Now they are associated with cholesterol stones. They are associated with cholesterol stones. They're associated with cholesterol stones, right? What is this? Is it a gallbladder carcinoma? No, it is not. Is it a polyp? No, it is not a stone. It is your cholesterolosis. It's called as cholesterolosis. That is strawberry gallbladder. This is your strawberry gallbladder. Look at the next question that we have. I have an 82-year-old female admitted with jaundice and colicky abdominal pain. The serum bilirubin and GGT were found to be elevated. Okay. Whenever GGT is elevated, remember it is because of obstruction to the bile duct. MRCP was done, reveals gallstone and CBD stone with the dilatation of biliary radicals. What would be the next step in the management? So you've already done an MRCP and you got the diagnosis. It is because of gallstones and CBD stones are present. So first preference is always given to clear the CBD stones and then you do a cholecystectomy. So we do an ERCP with balloon sweeping. with balloon sweeping of stone, with balloon sweeping of stone, with CBD stenting, with CBD stenting. Then I'll usually call the patient after 10 to 14 days to do laparoscopic cholecystectomy. This is the plan that we're going to follow. They're asking the next immediate step, then the answer is going to be ERCP. It is going to be ERCP. All right. So let's talk about the next question. So far, any doubts, guys? Quick feedback. Any questions? Anything that you would like to ask? Anything that you did not understand? Right. Chalo. Now, I have a patient found to have a serum bilirubin level of 2.5. So this is, as the question says, it's about Child-Pugh classification. So I already know that I have to calculate the CPC score, right? So when I say the Child-Pugh classification, the mnemonic to remember the component is what we call it as BAP, and BAP is energetic, right? So B stands for the level of bilirubin, A stands for albumin, another A stands for ascites, P stands for increase in prothrombin time, and E stands for encephalopathy. It is an encephalopathy. So we give a score of between 1, 2, and 3. So score of 1 is there, the score of 2 is there, and a score of 3 is there. So the score of 1, the score of 2, and the score of 3. Now based upon that, what is the criteria? We'll look at it. So bilirubin is measured as milligrams per deciliter. If bilirubin is less than 2, a score of 1. If it is between 2 to 3, a score of 2. More than 3, a score of 3 is given. Albumin 3.5 is normal, more than 3.51. If it is between 2.8 to 3.5, score of 2. If it is less than 2.8, a score of 3 is given. Ascites should not be present. Absence of ascites is a score of 1. Slight ascites, score of 2. Moderate ascites, a score of 3. How much does the prothrombin time increase from its normal value? If the increase is between 1 to 3 seconds, score of 1. 4 to 6 seconds, score of 2. More than 6 seconds, score of 3. Encephalopathy absent, 0. If it is minimal, 2, and advanced is going to be 3, right? So once you calculate the entire score, once you calculate the entire Child-Pugh classification score based upon the total score, right? You have class A, class B, and class C. We call it as class A if it is less than or equal to 6. We call it as class B if it is between 7 to 9. And we have class C if it is more than or equal to 10. It is more than or equal to 10, right? Now here they're asking to calculate, okay? The bilirubin is 2.5. It is 2.5, that means a score of 2 is given in bilirubin, okay? Then the serum albumin level is 3, that is between 2.8 to 3.5. So again a score of 2 is given. So another 2 we will add here. 2 plus 2 is 4 now, right? Another 2 we are going to add, that is 2.2, 4. The INR value was found to be 2, but we don't consider INR here. We have to prothrombin time, and there's a mild ascites which is present. The slight ascites, a score of 2 is given. There's no encephalopathy. If there's no encephalopathy, score of 1 is given. So plus 1. So 7 is the total score. 7 is Child-Pugh classification B. Answer is A for Ahmedabad. A total score of 7. CPC of 7 is going to be Child-Pugh classification B. Clear? Clear, guys? Chalo. All right. Moving on. Okay. Now, if you have a patient of renal cell carcinoma of size less than 4 centimeters, then how do you manage RCC of size less than 4 centimeters? Now, in order to understand this, first you should know the classification. We call it Robson's classification. So, what is this Robson's classification? We have Robson's classification for RCC. So what is this? Let's say this is the kidney. On top of the kidney, you have the adrenal gland. Covering all the adrenal gland and the kidney is your Gerota's fascia. This is the Gerota's fascia. This is the renal vein on top. Then you have renal artery. Then you have your pelvic-calcial system. This is your pelvic-calcial system that you have. Then you have the regional lymph nodes. These are your regional lymph nodes. Okay. Now, when you talk about the RCC, you look at the following component. If the tumor is less than 7 centimeters, limited to kidney, it is stage 1. If it is more than 7 centimeters, limited to kidney, it is stage 2. If it is not breaching the Gerota's fascia but involving the adrenal glands, if the tumor is involving the renal vein, or it is causing the into lymph nodes, it is a stage 3. If it breaches the Gerota's fascia, it is a stage 4. Right? So these are the stages. This is your stage 1. This is your stage 2. This is your stage 3. And this is your stage 4. Stage 1 is less than 7 centimeters. Stage 2 is more than 7 centimeters. Now, we say for stage 1, when you look at the management, for stage 1, we say whether it is at upper pole or lower pole. If it is upper pole, then you do a total nephrectomy. If it is a lower pole, then you do a partial nephrectomy. Then you do a partial nephrectomy for stage 1. For stage 2, stage 3 and stage 4, we do radical nephrectomy. We perform radical nephrectomy. In radical, we remove the kidney, the adrenal gland, the lymph nodes, and the ureter till the pelvic brim. Now, the question says that I have a 4 centimeter tumor. Okay, a 4 centimeter tumor is a stage 1 disease. But again, they have not given the pole. Radical nephrectomy I will not do, chemo I will not do. Okay, so here, rather than giving total nephrectomy, they have partial. So answer here is going to be partial nephrectomy. It is going to be a partial nephrectomy. Clear? Sure. Now, I have a 54-year-old female patient with abdominal pain and bilious vomiting. Okay. History of abdominal hysterectomy 2 years back. On examination, on abdominal auscultation revealed high-pitched bowel sounds. Okay. Investigation shows air within the biliary tree. Now, this air within the biliary tree indicates pneumobilia. So, here you have, number 1, there is signs of bowel obstruction, presence of bowel obstruction. There is presence of pneumobilia as well. Now, presence of pneumobilia, that is air in the biliary system, goes in the favor of regular triad. And in regular triad, if you add ectopic gallstones, now presence of these ectopic gallstones is what we call it as a regular triad. This is what we call it as a regular triad. And regular triad indicates gallstone ileus. The regular triad indicates this presence of gallstone ileus, right? So bowel obstruction, which is dynamic, you have pneumobilia, air in biliary system, ectopic gallstones, all 3 of them indicates regular triad, and regular triad is a telltale sign for your gallstone ileus. And the answer here is going to be gallstone ileus. See, I could have gone with additions also because the history of previous surgery, but here there will be no evidence of pneumobilia. For ischemic enterocolitis, there are severe abdominal pain, and that pain should be with minimal abdominal signs, pain out of proportion. For diverticulitis, there should be a history of diarrhea, which is not given, so all 3 of them is eliminated. The answer is going to be your gallstone ileus. Now, a patient underwent cholecystectomy for gallstones 2 years ago. Okay, She now presents symptoms of obstructive jaundice. Investigation reveals a stone in the common bile duct. What is the stone most likely to be? So what is a primary stone? A primary stone is stone formed within CBD due to CBD obstruction. That is, bile stasis will occur. And that is why the most common primary CBD stone is going to be brown pigmented stones. Now, secondary CBD stones are formed in gallbladder. They're formed in gallbladder but found in CBD. This is secondary. There's nothing called a tertiary as such, but we do have a retained CBD stone. That is CBD stone within 2 years of cholecystectomy. Within 2 years of cholecystectomy, right? So when you look at this here, the patient had a cholecystectomy 2 years ago. So it is already beyond 2 years, right? She is now presented with symptoms of obstructive jaundice. Investigation revealed the stone in the common bile duct, right? Now, because there is no gallbladder, it cannot be a secondary stone. Okay? There is nothing called tertiary, or only left with primary and retained. For a primary, there has to be a history of a CBD stone with secondary to and some sort of an obstruction. But for retained, it should be within 2 years. It is beyond 2 years, so I can take out the retained CBD stone also out of the picture. Answer here is going to be a primary CBD stone. If it is within 2 years, then it is retained. After 2 years, it will be considered as primary CBD stones. It will be considered primary CBD stone. Okay, a patient with an abdominal pain, sterile pyuria. What is the finding that you can see here? Now you can see the completely mushed out and calcified kidney, and this is what we call it as the putty kidney seen in renal tuberculosis. So this is seen in your renal tuberculosis. This is seen in your renal tuberculosis, right? It is not nephrocalcinosis. Staghorn calculi will have like a staghorn only. Psoas calcification will also not look like. Psoas calcification will have a linear calcification like this. You'll have down. There's a putty kidney seen in renal tuberculosis. It's the renal tuberculosis. Somebody is asking some doubt. What? Somebody says, team, please check this. क्या हो गया बेटा? Any problem? Okay. All right. So next question. I have an elderly male patient presented with sudden onset of scrotal pain and discharge. Based on the image, what is the likely diagnosis? It's a blackish colored discoloration, gangrenous. There is nothing but your Fournier's gangrene. A Fournier's gangrene is what we call it as the necrotizing. It is necrotizing fasciitis of perineum. It is a synergistic gangrene, right? Chalo. But for nephrocalcinosis, you should have specules of calcification, not the entire mushed out calcification. Clear? Any other doubts, guys? Any other doubt? Quick feedback. Okay, chalo. So going on to the next component. An intern was asked to calculate Q-SOFA score. Q-SOFA stands for Quick Sequential Organ Failure Assessment Score. What is the criteria for your Q-SOFA score? So when you look at the Q-SOFA score, in the Q-SOFA score, the first one is your systolic blood pressure. If it is less than 100 millimeters of mercury, score of +1. Second is going to be respiratory rate if it is more than that of 20 cycles per minute. Remember, in systemic inflammatory response it is 22, here it is 20, a score of +1. And if there is decrease in GCS, right, that is we call it as altered sensorium, a score of +1, right. Anything of more than or equal to 2 indicates poor prognosis, right. So what are you? Systolic blood pressure, pulse rate is not in the consideration, temperature is not in the consideration, respiratory rate, systolic blood pressure, and GCS. Yes, this is C for Calcutta. So there's no temperature here. No pulse rate, no temperature in your Glasgow Coma scale. All right. Sure. A patient presents with acute onset of severe abdominal pain. He is hemodynamically stable. An X-ray is shown below. What is the next step in the management? If you see the X-ray, probably you will now notice that there is free gas under right hemidiaphragm. There's this free gas under right hemidiaphragm indicating it's a hollow viscous perforation. For all hollow viscous perforation, take the patient for exploratory laparotomy. So here the answer is going to be not lavage, not ultrasound, not chest tube. It is your emergency laparotomy. So this is a free gas under right hemidiaphragm. Free gas under right hemidiaphragm. This is for hollow viscous perforation. This is for hollow viscous perforation. Okay, so okay, I have a man which complains of recurrent discharge and pain due to the lesion around the anus for 3 years. What is the likely diagnosis? It cannot be a pilonodal sinus because it is in the gluteal cleft. It can be a carbuncle because there will be acute and sudden discharge. There is nothing called as boil. So answer here is fistula in ano. You can see a lesion that opens here. Now, according to Goodsall's rule, if I draw a line which goes through the anal verge like this, right? It is on the posterior half. So for the posterior half, the tract is going to be curved. This is your Goodsall's rule. According to Goodsall's rule, you will have a curved tract. You will have a curved tract. There's a repeat question. It's the same putty kidney. It got double layered across. So same image, same component. It's a putty kidney, right? Okay. I have a 43-year-old male alcoholic patient comes to the OPD with complaints of pain in the hypochondrium with the history of loose stools 1 week ago. USG says 75 cc of pus was found to be present in liver. What is the next step in the management? Now, remember history of colitis, which is followed by liver abscess. History of colitis, which is now followed by liver abscess, is usually seen in amoebic liver abscess. This is usually seen in amoebic. So amoebic liver abscess. Now, amoebic liver abscess is not a true abscess. It's an example of liquefactive necrosis. So the first thing I will do is to start the patient on high dose metronidazole. And that high dose metronidazole is usually 700 to 1000 milligrams 3 times a day for 10 to 14 days. This is the dosage that we follow, right? So diagnosis here is going to be amoebic liver abscess. The diagnosis here is your amoebic liver abscess. Pair is done for hydrated cyst, that is your percutaneous aspiration, installation of scolicide agent and reaspiration, that is for hydrated cyst, not done. Medical management, yes, high dose metronidazole, no surgery. You can't reassure, you have to do some intervention. Answer here is B for Bombay. Medical management is high dose metronidazole, where it's going to be 700,000 milligrams 3 times a day for 10 to 14 days is your management that we are going to follow, right? Now, on the barium swallow, what do you see? On a barium swallow, you see there is an outpouching in the cervical region, and that is nothing but your pharyngeal pouch. also called as your Zenker's diverticulum, also called as the Zenker's diverticulum. So when I say Zenker's diverticulum, what are the important points? Number one, it is an example of a false diverticulum. Number two, it is an example of a pulsion diverticulum. It is a pulsion diverticulum. It is a cervical diverticulum. It is a cervical diverticulum. It is usually left-sided. It is usually left-sided. It is false. It is pulsion. It is cervical diverticulum. It is left-sided. And in Zenker's diverticulum, we say if it is less than 3 centimeters, then you do an open surgery. If the mouth of the diverticulum is more than 3 centimeters, then you do an endoscopic Dolman surgery. You do an endoscopic Dolman's surgery. You perform an endoscopic Dolman's surgery. Clear? Chalo. Now going to the next question. I have a middle-aged man presented to the emergency department with upper abdominal pain after having a heavy meal. Okay, on clinical examination, upper abdominal tenderness is present. Chest radiograph, widening of the mediastinum with pneumomediastinum seen. Was the probable diagnosis? Middle-aged, emergency department with abdominal pain after a heavy meal, on examination. These are the presentation present. Okay. Now usually there should be a history of vomiting also, right? It cannot be a perforated peptic ulcer disease because there is no mediastinal widening that occurs because of pneumomediastinum, right? And that is seen in esophageal perforation. It is not in the foreign body in the esophagus. It is not the ruptured emphysematous bulla of the lung because it is nothing associated with food. So here upper abdominal pain with heavy meal and all that is your spontaneous esophageal perforation. That is your Bohr-Haave syndrome, which you're going to have post-parental also. Okay. Usually when we say it is a macular striate, what is the macular striate? There's presence of macular striate. In macular striate, there has to be retching followed by vomiting, severe chest pain, and cervical subcutaneous emphysema. Your cervical subcutaneous emphysema. The cervical subcutaneous emphysema, all these are your macular striate. Now, next question. Chalo. In the next question, I have a 32-year-old male diagnosed with achalasia cardia. High resolution manometry result reveals massive simultaneous high pressure contraction in the distal esophagus. According to Chicago classification, what type of achalasia cardia is this? So usually I always tell in my class that in achalasia cardia, you have to remember two things. Number one, what is the IRP? The integrated relaxation pressure should be more than or equal to 15 millimeters of mercury. If IRP is more than or equal to 15, then I say the patient is having achalasia cardia. But this is not enough because based upon what are the components, you have three different types of achalasia cardia. IRP should be more than 15. But apart from that, how do you differentiate type 1 versus type 2 versus type 3? Now, in type 1, we use a word which is called as pan-esophageal pressurization. We use a word, one second guys. Right. So we use a word which is called as pan-esophageal pressurization. So you have to evaluate in the each single component. Okay. If you have any questions, guys, you can just put it on the chat box. I'll pick it up from there. Yeah, you don't need to do don't text directly. It's okay. Okay. If you have any problem, just put it there across. Now, in a type 1, how do you know? One thing you'll see, there's 100% failed peristalsis. There is 100% failed peristalsis. In type 2 also, there is 100% failed peristalsis with pan-esophageal pressurization. With pan-esophageal pressurization, and is the presence of premature spastic contractions. The premature spastic contraction, it is a type 3. So here what do you have? You have massive simultaneous high pressure contractions on the distal esophagus, right? So it says high resolution massive simultaneous high, okay, high pressure contractions are present. That means it is a spastic contraction. Spastic contraction is type 3. It's a type 3 achalasia cardia. It's a type 3 achalasia cardia. Okay, the next question, esophageal manometry is performed. It revealed a pan-esophageal pressurization with DCI, distal contractile integral, as more than 450. Now remember, whenever you're measuring the distal contractile integral, this is for diffuse esophageal spasm. If it is more than 450 millimeters of mercury, we say it is diffuse esophageal spasm. If it is more than 8,000 millimeters of mercury, if there's an 8,000 millimeters of mercury, then we call it as the nutcracker esophagus. It's a nutcracker esophagus, right? Now, so what do you think the answer is going to be here? Please answer my question. What is your question, beta? Sir, under air under diaphragm, if the patient is stable, we can do CCT as the next step or surgery. But investigational choice for hollow viscous perforation is your erect X-ray abdomen. If erect X-ray abdomen is inconclusive, then you go with CT. CT is not mandatory there, right? Okay, answer this question, beta. Quick feedback. So what is the DCI? That is a distal contractile integral in achalasia cardia. See, if the DCI is more than 450, no, see, do not fall into trap of pan-esophageal pressurization, because DCI in achalasia cardia is negligible. If you have DCI of more than 400, see, ideally this jack hand should not be given. The answer should have been a diffuse esophageal spasm, but still the best option here is D for Delhi. They're going to D for Delhi. Okay, this again same misprint, that is for spontaneous esophageal perforation. Just ignore this. Okay. A barium swallow examination is shown. What is the most probable diagnosis? In a barium swallow, this is what we call it as rat tail appearance, and the rat tail appearance is seen in esophageal cancer. So, sorry, I'm saying rat tail. It is okay. A bit tired. This is your apple core sign. Rat tail is seen in achalasia cardia. Let's not go into again spiral of the same problem. This is your apple core sign. This is your apple core sign, right? In achalasia cardia, you will get bird beak, you get pencil tip, you get bird beak, you get pencil tip, and you also see rat tail. So answer here is A for Ahmedabad. Beta, this is a repeat question. The same question we already discussed, no? This question. This is a repeat, just reprinted again. Okay, so the last question that we have for today. A patient with the carcinoma of the prostate, which has now spread to the vertebra. What is the route of spread to the lumbar vertebra? It is blood, and the most common vessel is going to be your Bateson's plexus. Those are valveless venous communications. Bateson's plexus are your valveless venous communication. It's a valveless venous communication, right? So answer, is it going to be prostatic venous plexus? Yes. Not transcoelomic, not inferior vesical vein, not the internal iliac vein. The answer is A for Ahmedabad. It is your A for Ahmedabad, right? So with this, we conclude all your previous topics that have been asked in your INI in last 5 sessions. We covered all the questions down there. If you have any questions, you can reach back. You can always pin me up on your Instagram, Telegram, or any other PWS platform or my personal channel. You're more than welcome to ask questions. Feel free to reach out if there is any topic that you want me to do a live session. I would be more than interested to doing that as well. Apple core is seen in colon cancer also. True, very good. But then in colon cancer, you will also see presence of hostrations. No, if there is no hostration, then it is esophagus. If there is hostration, then it is colon. That's the difference. Okay. Chalo. Thank you all of you. Thank you so much for spending last 2 hours with me. If you have any questions, any queries, please reach out. Until then, thank you. Goodbye. Take care.